everybody. My name is Craig Lockwood. I'm the Program Director for Implementation Science in JBI. And today it's my pleasure to bring you a brief PowerPoint introduction to JBI PACES and then move into a demonstration of how you might use it in a real clinical scenario. So PACES, as you can see from on screen, practical application of clinical evidence system. It's a software program designed to assist with a range of evidence-based implementation and implementation planning methods and methodologies. Some of those, for example, as you can see on screen, when you're looking to implement evidence-based practice, so you have some known reliable evidence, some good quality indicators for a change in care that are underpinned by evidence, and you want to move them into or through a change process clinically. It's useful in support for quality improvement projects that might relate to hospital sentinel events and KPIs, but also might relate to more specific unit type questions or issues or concerns as well. And it can be used to collect data for a range of kinds of research projects. For example, if you need incidence or prevalence data around maybe infection rates on peripheral intravenous cannula, or the number of people that come to hospital potentially with a pressure or decubitus ulcer versus those who are at risk of getting one while in hospital, you could collect incidence and prevalence data. And of course, the main uses for PACES are around evidence-based audit and feedback, implementation, and collection of outcome data. So there's a lot of rich possibilities for PACES, and it's intended to follow the interface of PACES follows the steps in setting up a project. So you start by creating a project. If you were doing audit and feedback, you then add criteria to that project and you collect data, and PACES will give you automated rapid analysis and presentation of that data as well. A few other useful characteristics of PACES around the ability to either use existing evidence-based audit criteria, and that's incredibly useful for, well, not just small to mid-sized, but also large organizations where if you're measuring practice, you want to be confident that what you're measuring against is best practice, not, for example, local performance in a different unit or in a different organization, or in my own conceptualization of what is reasonable practice. As an expert clinician, I might have a good idea of what is best practice, but the preferred case would always be audit criteria or quality indicators that are based on evidence. And whereas a user of software, I can click on that evidence and have a look at it to see what it says and make sure that it's the quality and nature of evidence that I'm actually really interested in. And then with the development of that, the other thing I can do is I can create custom criteria. So I might have 3 or 4 evidence-based criteria, but I need something specific and local, perhaps not based on evidence. I'll show you how to do that in a minute, because that's a fairly straightforward process. In terms of looking after different kinds of projects, PACES is designed to assist with the setup and management of projects where you just collect data once and maybe once only. So it might be on an annual basis, but no more frequently than that. Or it might just simply be a one-off project if you have students, for example. On the other hand, you might have a strong interest, and in my background as a dialysis nurse, I relate to this, a strong interest in collecting ongoing data around patient health, patient well-being, patient dialysis parameters, and any complications they might have occurred for those people. So that you can see strong parallels to quality improvement and safety and quality by using PACES. And the third type of data collection that you can do is called cyclic, where you might collect data on a routine process, but it might be at, say, 3, 6, or even 24-month cycles. The time frame is up to you, but you can certainly put in information, choose an approach, choose a start date, determine how frequently that will be, and to choose also a total overall duration of time. So it might only be 2, or it might be longer than that. You get to determine that because it's highly customizable as an interface. And one of the perennial questions that people have, of course, is what kind of sample size should I have in order to make a really useful determination of best practice? And so there is a calculator built into PACES that helps you to do that, where it asks you about confidence, what power, what do we think, here it says sample proportion, but really you could see that as being baseline compliance. So what is our current estimate of compliance with best practice? If it's 60%, that's pretty good. How do we want to try and improve? To what extent do we want to improve that? Would be our time to, and that will give us a recommended sample size. So PACES tries to do some of the heavy lifting for you in terms of setting up your project, in terms of having confidence about the sampling framework that you're going to use. And then it includes GRIP, which GRIP is the transformative piece of implementation in every context. So GRIP stands for Getting Research into Practice, and it is an embedded part of PACES that lets you actually do the situational analysis and contextual planning, but in a standardized, guided way. So the software provides the template, the parameters, the opportunities to input data from group planning, and then link all of that together into an action plan that you could take to a committee for sign-off, that you could use as the basis of education and training, that you could use to submit as part of a demonstration of safety and quality, underpinned by evidence-based practice as a driving indicator of quality in your healthcare facility or organization. And so GRIP is about change and a guided situational analysis to help people through a change process. And it is probably one of the key elements. Then, of course, there's outputs and data, which is essential to us all. So there are automated analytics in GRIP, or you can export to Excel and do further deeper analysis if you want to. But if you don't, as you can see on screen, PACES readily assists with the collection and immediate analysis and comparison of data between projects or between data collection cycles, if you like. And so you can see examples on screen of some pre and post information. If you were really interested in implementation as a broader construct and you wanted to get a bit more of a deep dive into how JBI thinks about implementation and the kinds of resources we offer in that area, then I would encourage you to go to that link and look at the JBI Evidence Implementation Manual. But for now, I'd like to just change to a different screen and take you on a short walk through JBI PACES. So this is the dashboard of PACES, and what you can see on here is that I have a number of rather unofficial projects underway, but I could click into any of those projects. I can also see the history of my activity in this project, and also the history of activity from other projects where I might be a member, but I'm not leading that project. There's also a really useful support desk button on every screen, and it just floats there. If you click that, it takes you through to some additional resources, plus the opportunity to go, help, I need assistance with A, B, or C. So that's the dashboard screen for you. But let's go with a working scenario. Let's say that we work in a hospital, a medium-sized hospital, where the executive director of nursing wants to know and wants some deeper organizational data on why rates of sepsis are currently a problem. There is KPI data on sepsis, of course, in every hospital, and there are well understood national averages. But what happens when our organization is trending above that average, and we want to be able to understand why is that trending above average, and of course, how do we bring that down? And PACES can assist with that kind of issue or question. It's of course, using evidence-based audit and feedback to evaluate current compliance with best practice standards. And so if we measure against best practice standards, we get some kind of indication of the degree to which that might help explain how or why we're trending higher than a national average might suggest we should. So the first thing we'll do is create a project. What are we going to do? We're going to give it a name. We're going to call it compliance. In the assessment and detection of sepsis across adult surgical inpatient units. Okay, so it's a descriptive title that helps us see actually what we're interested in, what population and what setting is involved as well. So this is a helpful way to think about framing these kinds of things. So given that the Executive Director of Nursing has advised on a particular topic and a particular strategic need, I want to know, are there existing evidence-based criteria I can measure against? I don't want to create my own and risk missing out on the opportunity for best practice. So I'm going to search for strategies to improve sepsis detection. Let's see what I come up with. Here we go. We've got a series of audit criteria. If I click the little arrow, then that tells me there are 3 criteria. I can click on the information button, get more about them, or I can click on this logo here, and this will upload in a new tab or a new window the evidence summary that JBI wrote by carefully screening the best available evidence and then summarizing it for me, putting it through critical appraisal, peer review, and then uploading it into PACES so that I've got reliable evidence sources underpinning my audit criteria. So these are, I can either click individually if I only want 1 or 2. That's just to illustrate for you, but I think all 3 are good. And I'm going to go with 3. And then you can see those are here now. I actually want an additional criteria as well, because we need to do some local work as well. And that might be around daily blood results. Right, so if we're interested in detection of sepsis, then the sooner that information is available to us, the quicker. This is either a yes or a no, so it's Boolean. But we could have done a sliding scale or continuous used checkboxes or even a range for different kinds of questions. I don't want that. I'm happy with yes or no. It was either done before 10 a.m. and the results are available by 10 a.m. or it's not. And I want a clear answer here. So I'm definitely staying with yes, no responses. If I work in an organization and we have an online policy, I could put in a link to that policy at this point. Or I can do a note in the audit guide so that whoever's collecting the data knows what are the exact parameters required before you can say, yes, this question has been answered. So let's try a note to confirm daily. The EMR, so medical record prior to. Now, the more specific my guide, which is how people will decide whether it's yes or no, the better. So I hope this is unambiguous in that the blood results have to be daily and they have to be available in the EMR, the electronic medical record, prior to 10 a.m. And if they're not, then the answer will be no. So now I add my custom criteria, and you can see I've got 3 from the evidence summary and 1 that meets a specific organizational need. Then what I want to do is to continue my project. You can see there's my criteria. This one's labeled as custom, so there's no confusion about that. And I'm happy with all of those the way they are. I'll press next again, and I need to add some sites to my project. I could add multiple sites and manage those. There's no limit to the number of sites you can choose. I'm just going to choose one site. And now I would add my team. So you add a team because these are people that will be involved in or supporting the project in some way. And there are two types of users you can add. So I'm going to add this, and now I can either add people as a data collector, which means they only collect data. They don't have access to other project parameters. And I can allocate them sites. So if I have more than one site, then I can allocate them to specific sites. But I'll just do that as an illustration of how it works. I can either save or come back, or I can continue. And you know that I want to continue, right? So we'll go here. We'll use the classic audit and feedback approach, which is a multi-cycle approach. And you can see then it adds our data collection options for us up here. But now this is the basic interface for setup, and it's done. So our project has been created. And as you can see, emails have been sent to the relevant people. So that's good news for us. Then I want to think about my sampling. So the first thing it wants me to do is to go, what kind of sampling do you want to use? Target is the sample size calculator approach, right? So you can use that, and that will just give you a recommended already, and you can modify any of those variables you want. I'm just going to actually go with a smallish sample size just for illustrative purposes here. If you have different questions, though, you can actually set the sample size calculator specific to the different questions. All right, so we've got our sampling done now, and you can see the different elements and processes along here. Obviously, what comes next is data collection. So we've got an opportunity now to move into data collection. There are two ways you can do data collection. You can enter every sample individually. So you can enter data for each question. In my case, it would be 13 times because my sample is 13 for each one. Or if you end up with five yeses and 8 no's, you can enter 5 and 8 as aggregate numbers, which we might do that for this one. So hospital offers education initiatives for staff on early recognition. We'll go with aggregate. As you can see up here, I could change that to individual and enter data 13 times for one question. But let's assume that I've collected my data already. So I'm staying on aggregate. And in terms of yes, we'll say we generally perform fairly well. And in terms of no, there's a little bit of room for improvement, and that doesn't hurt, does it? So I don't need to stay and submit a new record because I've done all the records for this question for baseline data. So that's organized now. Then I want to go back to my overview. Oh, I've forgotten to press submit. So let's press submit and go back to overview and continue. All right, so that's my first question done in its entirety. And my second audit topic was around formal screening programs. And this is more of an organizational characteristic than an individual characteristic. So hopefully for anyone that actually was grappling with this topic, that would be a yes. So we'll say that we've got that one well covered because that's at an organizational level, not an individual practice level. Patients presenting with signs or symptoms indicative of infection are assessed to facilitate early detection. And here, there's probably more room here for uncertainty in how we perform as an organization. So we might give this more of an even kind of distribution characteristic. So we'll submit that and then again, go back to our overview. It's very helpful software in that there's a consistency in the process and pattern every time, which a lot of users will really appreciate. So you can see we've done now 3 of our 4, and we'll just finish off with this is whether or not daily bloods are available. And again, this might be one of those ones where it's a system level accountability. And so generally it's high without too many omissions from the process. So let's assume the answer to that one is we've done fairly well. So here we are, we're in our project topic in compliance and assessment and detection of sepsis in surgical patients. We're in the baseline data collection cycle, as you can see up there. We've got the date and timestamp for that data collection as well. This is for all sites because we only have the one site in this example. And we've completed our baseline data collection. So if we go to report now, it'll show our current compliance against best practice. And that's the value here, is this is actually a measure of current compliance against best practice, not just how have we performed in general, which is what incidence or prevalence data would tell you. But we know that we've got a pretty much 100% compliance on having a formal screening program in place. And we'd be happy with that. That's systems level response to evidence need, and systems level responses provide a good gateway for safety. Then we've got daily blood results are available. So we've got just over 92% compliance there. And you'd want to discuss that. So there was an outlier, but there was only one. And that's a question for a committee or group to think about. What was the risk and what's the overlap and how much do we invest in a change process when compliance was over 90%. But visually, the easy ones to see are we could probably do some work on presenting with signs and symptoms, and also hospitals offer education initiatives. And if we want to make some improvements here, then PACES is helpful because it includes GRIP, which lets us then take this forward in a very particular way. So let's now go to GRIP. There's a few things you can do in GRIP, and this is indicative of how everything works here. So it's pretty obvious. If you're going to add people, you click here, you put in the project lead, who will that be? And then you add the details for the team or your stakeholders for the team. Just to show you that. In a demonstration though, we don't actually have to go quite that far. So we can go, well, we know in general, there is some room for improvement in compliance. So for example, compliance with staff education on sepsis wasn't bad, but maybe there are some things we want to deal with around having patients presenting with signs or symptoms indicative of infection being assessed to facilitate early identification of sepsis. And so that could be one topic of interest. Another might be maybe we do have a good education program, and the data suggested that because 10 out of the 13 answers were yes, but 3 were no. So we've missed staff and we've got a safety risk because of that. So if we took that one, then, for example, we might talk about the hospital education program. Now we can categorize these. So I could create a type called education if I wanted to classify what this is. But I'm just going to keep it simple here. So maybe I'll change that barrier description to, staff aware. Right, so maybe I've done some digging around and I've actually found there's a gap in people's knowledge about the education programs and the need to have their annual update complete and verified or validated. So that's a kind of a barrier. If people don't know that they're meant to have education and training, they're not going to reliably do it, are they? So I'll go with that as my barrier here. And then let's add that barrier, and then I can show you the next piece. Of course, you can change it here if you want to. You can make it specific to the individual criteria, and indeed it would be specific to this one. But for now, we'll just continue. So we add that barrier. Now that I've got a barrier here, you can see I've got the opportunity to add an enabler that is meant to be responsive to that barrier. So what I might want to do is change one of our administrative processes. So let's establish a new administrative process. And you can tell I'd be a tough educator to work for. That actually is the point, isn't it? It's about improving quality and consistency of care across an organization. And we can't reliably do that if there are gaps in the quality of care that we're delivering, nor can we expect people to deliver quality care if there are all systems level gaps in the way we support and enable them to be the practitioners that they want to be. So if we have that barrier of people not being fully aware of education and training, and we've established that we want to review, then implement a process for compulsory key performance indicator management, some strategies around that actually assist staff to become compliant with that would mean that we think about what are the systems-based processes rather than just tell staff they have to do better, because we all know that doesn't work very well at all. So we need to think about some pre-program sepsis training. So my suggestion here is we're going to integrate standardized calendar-based training for all staff. And that means it's not reliant on anybody's particular memory or individual responsibility. We want to do that. And our approach to doing that will be to hold multiple sessions per year. And monitor. We need to monitor it, because when we're trying to change practice to improve safety and quality or to implement best practice, we have to think about staff that might be on holiday or annual leave or off sick or on night duty, and give them an opportunity as well to be a part of the process. So normally if you were doing GRIP, you do it in a group-based process. And this gives you, as you can see on screen now, this gives you not just a barrier, so not just what is the problem, but also how might we address that problem? And if we're to do this, what are the specific strategies that would enable us to be responsive and to improve in this area? We can also export this as a PDF and then use it as part of committee meetings or reporting, or if you need to pass information up or down the ladder, for example. And in general, the more widely we share information, the more visible our program becomes, And so it's a really good idea. It's a good point of practice to regularly share updates about progress and things that you're doing in relation to evidence-based practice. Having spent some time on the implementation cycle, actually what you would do is then go back with it, maybe a few months later or at a defined time interval and measure again using the exact same indicators and the exact same guides and processes, because you want consistency there, and PACES enables you to have that consistency. Then that gives you the opportunity to compare baseline and end of project compliance to see to what extent did we shift the needle and improve compliance. And that, in a nutshell, is how PACES helps people with their implementation work.